Hello, everyone, and welcome to Headwise, the videocast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I'm the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. Today is our monthly headache news episode with Dr. Tim Smith. Hello, Dr. Smith. How are you today?
Doing well. How are you?
I'm good. Thank you so much for being here. So
Absolutely.
most people know that Dr. Smith is a regular on our show because of his experience with migraine clinical trials, as the CEO of Study Metrics Research. He is also a board member of the National Headache Foundation. We dedicate one episode each month to the latest headache and migraine, scientific and medical publications, news, FDA approvals, etc. We have some exciting information for you today, and I can't wait to hear what Dr. Smith has to say about it. So we are going to start today with a study that was just published looking at whether galcanezumab or Emgality was effective for women who had menstrually related migraine, which many of us are aware can be particularly difficult to treat. Once it shows up, it sometimes doesn't go away even with our best acute medications. So, Dr. Smith, what did they find with this study?
So this was this study, just to put a little detail on it. This was what we call a post hoc analysis of all pooled data from their pivotal studies. And so they were able to go through, and when they did the initial data capture, they had the participants, the female participants, document when their menstrual cycle began. And so they could go back and look to see what the perimenstrual period looked like as it pertains to response to the preventive effects. And basically what the study showed is that there is a preventive response to galcanezumab for those headache attacks during the perimenstrual part of the month. And this is, it's sort of interesting. We've done studies for interventions just around those sort of mini prophylaxis with medicines usually used as acute therapies taken daily for that perimenstrual portion of the month. And this was basically a drug that's already in the patient's system for month to month. So they take a shot once a month anyway. And this shows that their menstrually related migraines did respond and were prevented by the therapy.
Okay, that is great news because I think so many of us know that once it's there, if it's a migraine around the window of your period, it can be harder to get rid of than other migraines. And just really quick, can you define for us the perimenstrual migraines, menstrually related migraines? Is that within the 5-day window around your period? Is that what that is?
It's yes, it's a lot of people would quibble with us over that definition, but it is what we use for research purposes. Okay. Basically, it's the first day of menses minus 2 days and plus 2 days. So it's that 5-day window, and it's designed to sort of capture those female patients who will have migraine in the run-up to the start of their cycle, and then others who begin actually after their cycle, begins after the menstrual period begins. Okay. So that's why it's that way. It's not a perfect definition, but that's the one we use in research, and that's what they used for this project.
Okay. Thank you. So our next study we're going to discuss that was reported within the last month, it was in the Lancet, and it looked at whether taking Ubrelvy or Ubrelvy in the prodrome, meaning at the time of our earliest migraine symptom in this case. So in other words, not necessarily onset of migraine, but in the case of this study, they had people pick the earliest thing that lets them know there are migraines coming on. They were looking at whether Ubrelvy was effective in the acute treatment of their migraine attacks. If these people could guess that the migraine was coming based on these prodrome symptoms, which is so interesting. The reason this study is interesting is we would all like to nip migraine in the bud before it shows up, right? And so this is what they were trying to do. So please talk to us about this study, Dr. Smith.
Sure. This is a great study because it does answer that important question that you just outlined. And we've had trouble coming up with good study design to put some good science and statistics behind that notion. We as clinicians all have patients in our practices that can look us in the eye and tell us, I know when my migraine's going to come on, and I don't have any pain yet, but I know it's going to be a migraine. And if I treat early, if I treat before the migraine even begins, I can nip it in the bud, or I can, prevent it completely. So that, that's a notion that we're all familiar with. People have seen it and heard about it and lived it, but we don't have any very much good science about it. And so this study was designed to look at that more carefully. And what they did was they found patients that felt as though they had predictive symptoms of migraine, non-pain symptoms. So maybe a change in mood, maybe a change in energy level, maybe a feeling of stiffness of muscles, maybe queasy feelings, or a change in your digestive tract, and the list goes on. There's several that it could be, but if it was one of those things, and the patient felt they could highly predict that this was going to herald the onset of a migraine attack, then we screened those patients for the study. And then what we did is we put them through a sort of a proof period, a screening period, and they did prospective diaries, electronic diaries, where when they felt the symptom that they felt was most consistent with their prodrome, they would document that, and then we would see whether they went on to indeed develop a migraine, and they were allowed to treat with whatever they usually treat with. And then the patients who could accurately predict that they were going to have a migraine based on occurrence of symptoms, at least 75% of the time, so 3 out of 4 migraine attacks, those people could go on into the treatment portion of the study. And
okay,
then
so I'm going to pause there to make sure everyone understood that, because that's an important part of this. So they only enrolled people who, after following them, they knew could predict migraine coming 75% of the time based on prodrome symptoms.
Yeah.
So
they didn't just get people off the sidewalk and say, hey, can you predict your migraines? Well, here, try this.
Perfect.
They had to actually
prove it. Yeah.
Had to have proof that this was actually a phenomenon that was fairly reliable. And then, so in the treatment at the intervention part of the study, patients were given a dose of Ubrelvy, 100 milligrams of Ubrelvy, or placebo, and then they crossed over and treated another migraine with the opposite treatment. So every patient was exposed, if they treated both migraine, both prodrome attacks in anticipation of a migraine, they received placebo for one of the attacks and active Ubrelvy for the other one. They just didn't know in which sequence. It was randomly assigned. Investigators didn't know. And then the patients completed their diaries prospectively. And they basically showed that if they did the study correctly, they prevented migraine 46% of the time with Ubrelvy and 29% of the time with placebo. And this was statistically significant. We had not had studies that had good design that could reliably show that kind of separation. So it sort of validates something that we have always kind of known and presumed and wanted to be able to affirm our patients' approaches. And this sort of helps us, especially with this drug. It may be true of other drugs, but we've never seen those data on. This is the only one that has successfully done it this well.
Right. So that is, as I said earlier, the nip it in the bud hypothesis. We always say treat early, but we didn't have a lot of data to prove that worked, and that study did show it. So that was good data. So we're going to move on to a study related to the Nerivio device, which we've spoke about before on Headwise. This study was carried out in adolescents. And the interesting thing about this study, we want to make sure we get across, is it is another one of those things that in the migraine and head pain community, we always have wanted to believe that by treating our migraine acutely and decreasing the frequency, we are decreasing our future migraine attacks. It's something we've always wanted to believe, but we've never necessarily shown it. And that's sort of what was going on in this study. So talk to us about this work that was just published related to Nerivio in adolescents.
So a few things is we've said before, we're always excited to report out on anything for, adolescent
Yes.
migraine patients. And so this is yet another one. The folks at Nerivio that make Nerivio Theranica have done an excellent job of trying to champion this population of patients, and we appreciate that very much. The second thing is that this is some real world data that is aggregated by the folks at Theranica, and basically by virtue of patients using the device, they are in a good position to be able to capture, contemporaneous data about the migraine attacks and their response rates. So that's given them a very robust way of reporting these large studies, where we can see get some insights as to response rates and populations of patients. And then thirdly, you alluded to the fact that we have this observation and belief that if a patient has really, really good acute therapy, that decreases the opportunity for them to develop what we call central sensitization and amplification of their migraine. So better abortive therapy or acute therapy to turn migraine off in the first place decreases the need for preventive therapy. Okay, so and what they showed in this study was these adolescent kids who started on treatment at baseline, they had on average had 12.6 migraine days per month, and that is a lot, especially for an adolescent, for anyone, but your adolescent kids out there with that many headache days, it's horrible to think about, almost half of their month being predominated by these migraine days. But in the second month, they were of just routine acute use, using it to abort headaches, not preemptively or preventively. After using it for a month, their monthly migraine days were down to 9, and then in the third month they were down to 7.4. So it's more than 5 migraine days taken off of these patients per month on average, and that rivals what we see in preventive studies, or for some preventive studies it's better. So we appreciate their efforts for trying to track these outcomes and report them to us. It's observational data, so we understand where it comes from, but I think it's very useful, and we're glad they're doing these kinds of studies and putting these results out for us to see.
Right. And I think that it's a hopeful, it makes me feel hopeful when you see something that you're using to decrease your pain now is decreasing your future pain, if that makes any sense. I like the idea of that. So our next study, I love genetic studies, being someone who comes from a family where we are 3 generations now where we all had daily migraine before the age of 10. So genetics I love to hear every time we learn more about migraine and genetics. So we have a new study out of Iceland, and it had some interesting results, looking at different genes, both in migraine with aura and without aura. And they found some interesting things. So can we summarize what they found?
So these researchers took data from what they call genome-wide associations, and there have been these studies that are going on in many countries, and they pool data from 6 European countries. And what they do is they just provide the code of doing a genomic analysis for the entire genome for these patients, and they take extensive histories, and so they can know who has migraine with aura, who has migraine without aura, any other diagnoses. And if there's an association with the presence of a mutation or a gene sequence that tends to track with that disorder, then we see that association exists, and it could be that it's involved with the development of it. And it's particularly interesting if there's a really, really strong predictive signal from those things. So this, we're going to see more and more of these analyses going forward. The problem with migraine is we know that it runs in families, but before the human genome was mapped and before we could do these genome-wide association studies, we couldn't really start to zero in on which genetic defects or genetic variants, I guess we should call them. It's you don't want to call it a defect if it's just part of a normal.
Are you saying I'm
variant.
defective? Just kidding.
If you are, I am. So I'm in good company. But anyway, it's these kinds of studies I think can be very instructive. This one in particular showed that they identified 4 newly identified variants that were associated with migraine with aura, but not migraine without aura. And then they identified 13 other variants that were associated with migraine without aura. I think it's very interesting that these variants are lining up according to migraine subtype, and the more we know about these, you get into that branching logic, and you start to see other subtypes coming forward, we hope, as we learn more and more about these. And I think the other, just to put a quick fine point on this, is there were 3 of the variants that were rare, but they had very large effect. They were highly associated with the particular outcome. And it's one of the variants for PRRT2 was highly associated with increased risk of migraine with aura and with epilepsy. Interesting. And we know that some of these sensitive central nervous system disorders can be associated, and this is pointing to a gene defect that is associated with both of them. There could be a partial explanation in that for us. And then there were 2 others that I thought was very fascinating, that the SCN11A was associated with a decreased risk of migraine. And we don't typically think about looking for a good outcome, but that's maybe we should,
Right.
And then another one, KCNK5, that was associated with decreased migraine and also decreased incidence of brain aneurysm. So that was kind of an interesting thing. Is there some kind of causative thing that could be linking some brain aneurysms to some types of migraine? It's kind of a scary thought, but it doesn't prove a cause and effect, but it's certainly the association is there, and we find that very interesting. But I thought that these last 2 that were rare but really had a powerful association were actually linked to decreases in migraine, and that may explain these people you see in your everyday lives that say they've never had a significant headache, and I'm like, what's wrong with you? Everybody I know has a significant headache every now and then, but there are people who can look you in the eye and honestly say, I've never had a migraine, never had a significant headache. Perhaps they're protected by one of these variants. Who knows? But it's food for thought.
I know. I find that so interesting, and I'm glad to know now that next time I meet one of those people, not only do I have nothing in common with them, they very likely have a gene that has clearly never been anywhere near anyone in my family. So
we call them a mutant.
Yes. Well, we will call them a mutant. Yes. We're the normal ones. So anyways, well, thank you so much. That was a very informative, interesting, and even somewhat fun news episode. So thank you, as always, for being here with us, Dr. Smith, and thank everyone for tuning in to this week's episode of Headwise and this month's news episode. Please join us again next week for the video cast and podcast of the National Headache Foundation. Bye-bye, everyone.
Right.